Thank you very much for having me here to speak in this session. Those are my disclosures referring to this presentation. I'm going to quickly show, because David and the previous speakers introduced the subject on the results of metabolic surgery. So the outcomes in grade 1 obesity so far, the safety of the operations in lower BMIs, the definition of metabolic surgery, and the current recommendations in one single slide. David showed this already within the results in observationals and RCTs in BMIs over 35. In all of them, regarding glucocentric endpoints, surgery gets better outcomes than the medical treatment. Results in BMIs below 35, if you look at this very big systematic review meta-analysis done by Simona Pannunzi from Italy that works for Geltrudin Mingroni, with 94,579 patients. If you look at the outcomes or glycemic control or decrease of A1C below 7 in BMIs below 35 and over 35, diabetes remission is the same. So actually, the baseline BMI makes no difference in long-term outcomes. If you look at Phil's study, the Stampede 3 years, and if you pay attention with the patients stratified in BMIs below and over 35, you'll see the results are pretty close. So again, in this level 1A evidence, although it's not a full cohort of BMIs below 35, in these percent of patients with BMIs below and over 35, the results after a sleeve or the gastric bypass are very, very close. If you look at the glycemic endpoint in RCTs with the shorter and longer follow-up with ascending baseline BMIs that David showed in one of his presentations, we're going to see here that the results favor surgery in most of the studies, except one, that's the DING study, where he compared the adjustable gastric banding with the best medical treatment, and the results were similar. The rest of the studies favored surgery when you compare to the very best medical treatment. We conducted a systematic review and analysis on the level 1A evidence in patients with malobesity, BMIs 30 to 35, and diabetes remission at the longest follow-up of each study. If you look at this forest plot, in all of the study, they favor surgery. The same in A1C reduction in only level 1A evidences in patients with BMI below 35. Again, if you look at A1C reduction, it favors surgery. Blood pressure reduction, it's a mixed result because all of the studies were not powered to detect outcomes in blood pressure, but even though more studies favor surgery regarding reduction of blood pressure, and there's a significant increase of HDL cholesterol after surgery in BMIs below 35. So yes, in level 1A evidence, we have a strong effect of surgery over diabetes and over all the triple endpoint of the ADA. This is a Chinese population, a prospective match control study. It's not a randomized control one. Medical treatment versus surgery. The surgical group was divided into two arms, a Roux-en-Y gastric bypass and the sleeve gastrectomy. This is the definition of the study: complete remission A1C below 6 without medication and fasting plasma glucose below 110, partial remission A1C below 6 and 6.5, and the fasting plasma glucose between 110 and 126 milligrams per deciliter. What I found is, yes, there is a significant reduction in weight if you compare the surgical arms versus the medical treatment, as we expected. More pronounced effect after the Roux-en-Y gastric bypass, and complete remission A1C below 6 without medication and fasting plasma glucose below 110, 40% in the Roux-en-Y gastric bypass group versus 17% in the sleeve, but much better when they compare the medical group versus the surgical arms. So even in this Chinese population, surgery outperformed regarding glycemic endpoints the best medical treatment. This is, to my knowledge, the longest follow-up in patients with submitted to Roux-en-Y gastric bypass in BMIs 30 to 35. We did this in a collaboration with David sitting here at the table. Those were 666 Caucasian patients, 100% followed by 6 years, BMI 30 to 35. Type 2 diabetes was confirmed, and diabetes was really a severe status. Mean duration of diabetes 13 years. 40% of the patients were under insulin, and A1C at start was 9.7%. We define remission as A1C below 6.5 without medication, improvement A1C less, below 6.5, but less medication when compared to baseline, and unchanged when compared to baseline. We had at 6 years, 88% in the remission class of diabetes remission. There is a rapid, probably independent reduction of A1C that kept stable and down for 6 years. The same with fasting plasma glucose. And there was a significant improvement in lipid profile and significant improvement in systolic blood pressure. We plot all the data in the UK PDS risk engine for the 10 years prediction of cardiovascular events, and we could achieve, comparing the pre-op in gray versus the red, the post-op, a decrease in coronary heart disease, fatal and non-fatal, and the same fatal and non-fatal stroke. So surgery is really powerful, reducing the cardiovascular risk factors. At 8 years follow-up, this is unpublished data. We're waiting this year to complete 10 years. We lost 4 patients of follow-up. We had 16.5% of patients that recurred diabetes. They were all in the 88% of complete remission. But we have downgraded the severity of the disease. 10% were back only to metformin in full doses, 2 grams per day. Only one was back in combinations of vildagliptin plus metformin. But all of those 11 patients, the 16.5% of the recurred patients, they had a pretty good weight loss long-term. So recurrence probably is due to the severity of the disease that was really downgraded after the Roux-en-Y gastric bypass. Is it a safe operations in BMIs below 35? As David mentioned, we had this officially approved in Brazil by our National Health Authority back in November 2017. And this was a major question because that health authority plus the endocrinologists down in the country thought that surgery could be more dangerous than in BMIs over 35. Well, if we take our data and the expected and found in our study comparing to the lab study, mortality was 2.2% in BMIs over 35 in the lab study. No mortality in ours, major morbidity 4 to 5%. We had no major morbidity in this small cohort of 66 patients. Minor morbidity was very similar to literature, the LABS 2 study. And another an issue that worried everybody was excessive weight loss. Our minimum weight loss in this cohort was 23 of BMI. If you look at all the studies published today in literature with BMIs below 35, the last BMI we found is in Camilo Bosa's study in Chile, 22.2. So it's a very safe, it does not deliver excessive weight loss long-term. Is it safe regarding mortality? This is Ali Aminyan's and Phil's paper. 1,300 patients with BMI below 35. 30 days morbidity was 4.2%, severe adverse events of 0.7%, and mortality 0.15%, very similar to all bariatric metabolic surgery in any BMI. This is an editorial we wrote, David and I, that actually we need to prioritize patients that are really sick and not if they're heavier or leaner. Actually, those patients that are prone to have cardiovascular events and mortality. So this lead us to define what is metabolic surgery. So when we started back doing duodenal jejunal bypass, that we did this in 2005 with patients below 30 of BMI even, the mean BMI was 28.9. At that time, it was the first surgical proposal to treat specifically diabetes, not looking at weight loss. And what we can, at that time we thought that metabolic surgery, this is 2005, 2004, we thought that metabolic surgery should fit into patients with BMIs below 35, and that is not true. It is any procedure over the gastrointestinal tract that aims to put diabetes and the other metabolic syndrome components under control through weight loss independent and weight loss, and independent and dependent of weight loss, regardless of baseline BMI. So BMI, it's still a marker for us, but I think it should be replace long-term to the severity of the disease. What matters is to treat a disease and not only the weight, the relation of the weight and the height of a patient. Another question that I had when we could prove metabolic surgery in Brazil is that the total number of patients was too small, but the effects of surgery are really massive and they're unquestionable. It's really powerful, mainly regarding glycemic endpoints. So any powerful effect of any treatment needs a lower number of patients to prove that is efficient. This is like the parachute theory. I don't need 2,000 patients jumping from an airplane without a parachute to prove that using a parachute may save lives. So the number needed to treat to achieve full remission in our meta-analysis published in Obesity Surgery last week, to achieve full remission A1C below 6.5 with or without medication over 5 years is three patients. So it's impressive that the calculated type 2 diabetes progression and the decrease of cardiovascular risk is close to 20 times when surgery is used with medical treatment. There are some gaps in the evidence for surgery. We don't have RCTs with over 5 years of follow-up to prove the durability of the glycemic improvement. We still don't have RCTs power sufficiency to demonstrate the reduction of microvascular and macrovascular complications of diabetes. There are some RCTs that are coming to prove that surgery and the best medical treatment really can treat microvascular complications. But if you look at the major clinical medical studies, the EMPA-REG, the CANVAS, and the LEADER, they still don't have long-term follow-up. They prove decrease in mortality in around 3.5 to 4 years of follow-up. So actually, the gaps for surgery and the gaps for the medical treatment with drugs that decrease mortality rate are the same. I'll skip this slide. David showed this is the DSS-2 recommendations for surgery. Brazil is the second largest volume of metabolic and bariatric surgery in the world. We do 110,000 operations per year, and we are the first high volume country to approve surgery in BMIs from 30 and above in patients with uncontrolled diabetes. So I can tell you that since November, the volume of patients looking for surgery increased in about 25%. So patients that were not allowed to do the operation, now they're looking for surgery. So the DSS recommendations really change our landscape to treat diabetes. And finally, there's some landmark things that happen on Earth. The discovery of fire. Galileo discovered that the Earth circles the sun. Newton discovers the gravity, and the ADA finally recognized us as a good therapeutic option to treat diabetes. Thank you very much.